Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through the pharmacology for angina and a myocardial infarction, which is a heart attack. Let's begin with a patho review. Angina is when the oxygen demand exceeds the supply in the heart. So the patient is at a time of increased oxygen demand, they're exercising, they're stressed, something else like that's going on, and the heart cannot deliver enough oxygen, you end up with angina. The classic symptom of angina is chest pain or chest discomfort. Now, there's two types of angina. There's stable angina and unstable angina. Stable angina is what we're going to talk about, and that's where the chest pain comes in a predictable pattern. For example, the patient understands that every time they go for a jog, their chest starts to hurt, and it stops when they sit down for a few minutes, or it stops when they sit down and take nitroglycerin, something like that. That's classic angina. We're not going to discuss unstable angina, which is where it deviates from the normal pattern. Next, let's talk real quick about a myocardial infarction. That's a heart attack, and a heart attack happens when there's an obstruction of one or more of the coronary arteries, meaning that to a part of the heart, there's no longer any perfusion. When there's this usually results from plaque or a thrombus. Plaque is lipid or some other buildup, or a piece of it, and then obviously a thrombus is a blood clot. Very often it's both. It's where, let's say, a patient has a piece of plaque that's been sitting in their artery for 30 years, it goes for a swim, maybe some clots start to form around it, it gets bigger, eventually it gets stuck in one of the coronary arteries. That's an MI. Now, when a patient's blood vessel is obstructed with a thrombus or a piece of plaque, now there's no longer any perfusion past that site. So if we're talking the coronary arteries, now we have a part of the heart that's not getting perfused. Those cells are going to become ischemic, hypoxic, eventually injured, eventually they will die. So let's go back to angina and let's start with the first medication. The first drug we're going to talk about is nitrate, and that is a vasodilator, and the drug is nitroglycerin. Now, vasodilator is a pretty broad class of drugs. Some textbooks that you're going to be using call nitrates a vasodilator, which they are, but some go more specifically that it's a nitrate. At any rate, the drug we're talking about is nitroglycerin. This is certainly going to be a tested on drug in nursing pharmacology courses. The way the drug works is it dilates your veins. So what does this do? This increases the perfusion to your heart by increasing preload. Again, it increases perfusion to your heart by increasing preload. So it increases the supply to your heart. Now, again, in case I got anyone confused, we are talking now about angina. This is a drug used for acute angina. So when a patient is not having enough supply meeting the demand of the heart, we increase the supply by vasodilating. This increases the blood flow to the heart, which increases perfusion. It increases that oxygen supply. That's how it treats that angina. Now, we also use this for heart failure. We're going to discuss that a little bit more extensively in the heart failure video. But again, same concept where the heart is failing to pump out the amount of blood that it's supposed to pump out. This increases the amount of blood that's returning to the heart, thereby allowing the heart to pump out more blood. I did put one quick note in here. This really shouldn't be tested on at the RN level, at least not in my opinion. But at higher doses, when a patient gets a really high dose, and we're talking IV of nitroglycerin, it can start to dilate the arteries instead of the veins. But almost always, and certainly in nursing pharmacology world at the RN level, we're going to be talking about it dilating the veins, which is what we standard use it for. The side effects of this drug, the classic side effect is a headache. In fact, almost everyone's going to get it. Also, it can cause orthostatic hypotension, as well as reflex tachycardia. This medication is available by several routes. It's available sublingual, transdermal, IV, and PO. I want to make one thing really clear because I've seen this in a bunch of nursing test banks. The transdermal route is where we put it on a piece of on a Band-Aid or something like that, not a Band-Aid, but a specialized application material. We put the medication on there and we put it on the patient's chest or arm or back, something like that. And we give the medication transdermal. When we give it in that route, it can be either for acute angina or chronic angina, which we're going to talk about in a few minutes. But the transdermal route can be used for both. As opposed to the others, the sublingual, IV, and PO, those are all used for acute angina. Next, when a nurse is handling the medication, and we're talking now specifically the sublingual one or the transdermal one, make sure you're not touching it directly because you can be affected by the medication. So make sure you're wearing gloves. Obviously, that's most important when you talk about transdermal, but even the sublingual ones, you shouldn't handle those tablets with your bare hands. Next, when a patient has acute stable angina, which is what we're talking about, the medication is dosed at 0.4 milligrams per tablet, which is 400 micrograms per tablet. Now, I have seen this in nursing school test banks. Very rarely do we test on doses, but this is one of the times where we actually do. So even at the nursing level, you should know this. Now, the medication, the tablet or the spray, it's available in both for the sublingual route. The tablet or the spray goes sublingual. That means it goes under the tongue, and we just let it dissolve there. In either case, the dose is that the patient can get 1 tablet or spray every 5 minutes, up to 3 total doses. Now, standard, certainly for nursing tests, obviously doctors can override it, but the standard treatment is going to be up to 3 doses of that sublingual nitroglycerin. By that point, either we realize it's not working, or we got the desired effect, or we switch them to IV, or their blood pressure is too low. A whole bunch of stuff can happen, but per the textbook, you can get it up to 3 doses. Now, every single time before and after you give this medication, you need to reassess the blood pressure. And if you've seen enough of my videos, you know every time you reassess one vital sign, please reassess all the vital signs. It's a great habit to get into. When you're reassessing them, do keep in mind, don't just reassess, document, and move on. Pay attention to that blood pressure and make sure it didn't drop. Also on nursing exams, check that blood pressure, because if it dropped, you may not be giving the next dose, even if they've only had 2 so far and you're still allowed to give a 3rd. Next, if a patient is being educated about this medication, again, they're educated that they can take it up to 3 doses every 5 minutes, but they need to be educated if they are not getting relief after 3 doses, they should call 911. I'm going to tell you something else, and this isn't in your textbook, but if a patient always gets relief with 1 dose, and today the 1 dose didn't give them relief, yes, they should take a second, but they should also probably be considering calling 911, or at least getting themselves to a hospital. Next, this medication, the nitroglycerin, is used PRN as the first-line agent for stable angina. Stable angina, again, is that classic, I know every time I walk 50 yards, I get out of breath, I need to sit down and take a nitro. That's stable angina. This is the first-line medication for it. Next, when we talk about chronic angina is a little bit different. So let's talk about that here just for a second. When we talk about chronic angina, we're talking about this patient that every time they go, let's say 50 yards, they get out of breath. And they take a nitroglycerin, they sit down, and they're all better. But they go to their doctor and say, this really isn't working for me. Can you please give me a medication that I don't keep getting this short of breath and I don't have to keep taking my nitroglycerin? So this patient may be placed on a chronic or long-term medication for the treatment of angina. In this case, the patient's going to take their medication not when they are acute, not when they're having chest pain, but they're going to take it every single day as a regular daily medication, just like your blood pressure or your cholesterol medication. Now, in this case, the medications we use are as follows. We can use a beta blocker. We can use it, which we're going to talk about next. We can use a calcium channel blocker, which is not the go-to medication, and therefore I only discussed that in the hypertension video. I'm not going to discuss it again here, other than mentioning it. We can use ranolazine, which we'll discuss in a minute, or we can use this. We can use nitroglycerin, but specifically transdermal nitroglycerin. So again, especially for testing purposes, when a patient has acute stable angina, meaning they have their predictable chest pain, we give them their medication when they're having chest pain. That's going to be nitro, sublingual. We give it to them, relax, pain goes away, up to 3 doses. If the patient has told their provider that this is happening too often, I want to be on a daily medication for my angina so that I don't keep needing to take my nitro, in that case, they may be prescribed a beta blocker, which is first line, and we'll get to in a minute, or they may get transdermal nitroglycerin prescribed to them. In that case, the patient is going to be instructed as follows. They're going to be instructed to wear the patch 12 hours a day, no more, and only wear it 6 days a week, no more. That's what this next bullet point says, requires a dosification, because if they wear it 24/7, they're going to get a buildup to it, they're going to develop a tolerance, and it's no longer going to be effective. So we don't generally use transdermal nitroglycerin as the preventative medication, as the long-term management medication for chronic angina. However, if it is an appropriate medication, and certainly for test purposes it is, so in that case where we are using it, know that it's not the ideal option. It's only the transdermal route. It can only be worn about 12 hours a day. Some books I saw say up to 16 hours a day, but certainly not 24. And it should only be used 6 days a week, not 7. That's what I have to say about transdermal and nitroglycerin being used as a preventative medication for angina. Next, nitroglycerin is contraindicated if the patient took sildenafil, vardenafil, or tadalafil. You may know those better as Viagra, Cialis, Levitra within the last 48 to 72 hours. Nitroglycerin is contraindicated if the patient is having a right-sided MI or has closed angle glaucoma. You may not know about the closed angle glaucoma. You may not even know about the right-sided MI unless you've done an ECG already, and you know how, and someone that knows how to look at it has said that it's possible right-sided MI. If you don't know any better, then we don't just assume it's a right-sided MI. We can go ahead and give the medication. It only becomes contraindicated when we start to suspect or confirm that it's a right-sided MI, and that I'm going to leave the why behind that to your adult health or med surg class. Next, hypotension related to nitroglycerin, which we just said is a common side effect, is treated with fluids. Keep this in mind. By the way, when a patient's blood pressure drops from nitroglycerin, you may very well be told by the provider, give the next dose. It's okay if the blood pressure drops, but give them some fluid with it. And next, make sure you're always assessing your blood pressure, and especially on nursing exams, make sure you're always watching the blood pressure with nitroglycerin. So far we talked about angina treatment for acute. I have that chest pain. My heart is becoming ischemic because the demand is increasing, is higher than the supply. I take my nitro, that increases the supply, and my chest pain goes away. Everything's good. If I am having this happen all the time, I tell my provider, and they say, how about we put you on a daily medication so that this doesn't keep happening? Obviously, exercise and lifestyle changes is for sure the best option, but there's also the pharmacological option, which is what we're talking about. So the first line drug for that case where a patient wants to be on a daily medication, even though I have no chest pain right now, but this is happening to me all the time when I exert myself, beta blockers is the first line drug. We discussed beta blockers in length in a bunch of other videos, including adrenergic and hypertension and heart failure and dysrhythmias, but I'm going to go through it a little bit quicker here since it's covered so often. The drugs of beta blockers, these are the LOL drugs. We have propanolol, metoprolol, atenolol, esmolol, and about 15 others. We also have labetalol and carvedilol. When we talk about giving it for angina, there is no one specific go-to medication. I think metoprolol is probably one of the most common ones that we use, but there's no go-to. The provider would make a decision based on their cardiac comfort and their knowledge of what's going on with the patient and the specific characteristics of the medication. The mechanism of action of beta is that it slows down the heart. So if it slows down the heart, that decreases the demand. Remember, the problem was the demand is too high for the supply. So this decreases demand. It fixes the supply and demand problem. What do we use beta blockers for? We use it for so many things. We use it for angina, which we're talking about today, high blood pressure, heart failure, AMI. I'm not going to go through the whole list. Again, I'm doing it quickly because we've covered this drug class so many times. The side effects of this drug class are fatigue, bradycardia, hypoglycemia, and sexual dysfunction. All of those are fair game as test questions. Let a patient know that they may be more tired, especially when first starting the dose. Let a patient know that their heart may be slower than normal. They may not have as much energy when they first start the dose. Hypoglycemia is a commonly tested on one, so definitely make a note for yourself on that. Sexual dysfunction, this is primarily males that are getting into older age, 50, 60, 70, 80, that if they take this drug, they may end up with sexual dysfunction. Recommend that the patient note this to the provider so they can be prescribed an appropriate medication or other recommendation to treat that. It does have a black box warning that you shouldn't suddenly stop taking it because remember, this supports the heart. So if I suddenly stop and take away that support from the heart, that's obviously a bad thing. We mention this every time we mention beta blockers because so many tests love to ask about this. But if a patient has an underlying cardiac condition, most commonly COPD, but technically it applies to pneumonia and anything else as well, if they are taking one of the non-selective beta blockers, it can worsen their underlying pulmonary condition. Again, if a patient has an underlying pulmonary condition, primarily COPD, and they're taking a non-selective beta blocker, it can make it worse. In real life, that's really not that big of an issue, but nursing tests love to ask on that, and it's certainly fair game. Finally, make sure you're assessing both heart rate and blood pressure every single time you're giving this medication, both before and after, because it affects both. And obviously, if you're assessing one or two in this case, assess them all. Next, we have ranolazine. Ranolazine is not a newer medication, but a lesser used medication. It decreases oxygen demand. Again, we know that's the whole problem in angina. We don't know exactly how it does it. And the only thing we use this for is angina prevention as a daily medication. It does have an adverse effect of QT prolongation. I looked through all the nursing textbooks. You shouldn't really have to know anything more than that. Let me wrap this up. Angina is treated acutely when the patient's actively having chest pain with nitroglycerin sublingual. That can be taken up to 3 times. If it's given in a hospital, it can be also given via the IV route. If a patient is having chronic angina and they want to take a daily medication so that they don't keep having this chest pain, beta blockers is our go-to. Other option is ranolazine. Other option is transdermal nitroglycerin, which works for both acute or long-term chronic management. And finally, calcium channel blockers is another option that can be given for the chronic management of angina. Let's move on to talking really quick about an MI. I'm only going to go through one drug class here, and this drug class is also covered in the anticoagulation lecture. But let's go through it quickly here. Thrombolytics is the only pharmacology drug that is solely focused on treating a heart attack, and it's used for a heart attack, a stroke, or a pulmonary embolism. This is the only drug in existence, at least as of today, that can break up an existing clot. How does it work? It initiates fibrinolysis, which is the breakdown of clots. This is an IV-only medication. This is a very high-risk medication. There's an extensive checklist that every single hospital requires be used before the administration of this drug. This drug is given in a loading dose, followed by a maintenance dose. The biggest adverse effect of this drug is intracranial hemorrhage. It can also affect your heart rate and dysrhythmias. Those are other side effects that can happen. But the biggest one, certainly on test banks and in real life that we look for, is if the patient starts to develop a brain bleed, which is intracranial hemorrhage. This medication, when a patient's on this medication, you shouldn't be sticking them for IV or doing any other invasive procedures while they're on it, because they're going to be at higher risk for bleeding. And if they develop uncontrolled bleeding from this, you should treat that with cryoprecipitate. Now, lastly, before we leave this lecture, medications that are given in general for a patient with having an MI, and all of these are discussed in this lecture or other lectures, but you should see this list because it's fair game for your nursing school test. The first is aspirin, most commonly a baby aspirin if it's taken for chronic prevention of heart disease, or if the patient is having an acute MI, then it would be 324 or 325 milligrams of aspirin. Nitroglycerin we just talked about extensively. And anticoagulant. Now, this is not the thrombolytic I just mentioned. Anticoagulant is where a patient gets heparin, and that's one of the acute drugs a patient gets when they're having an actual heart attack. They may also get an antiplatelet. Aspirin was an antiplatelet. They may also get another one, such as clopidogrel, which is Plavix. And again, we discussed this in the anticoagulant lecture. Very often when patients have a heart attack, they're also put on a statin. And very often they're put on it immediately right there in the OR. They're already given their very first dose if they've not already been on it. And that's going to continue usually for the rest of their life. Finally, if the patient's hypoxic, they're going to get oxygen. If the patient's in pain, they're going to get morphine. You would not get either of these if there's no need for it. If there's no pain or if there's no deficit in the oxygen, the pulse ox, you're not going to get these drugs. But again, a patient is having a heart attack while they're heading off to the cath lab or whatever definitive treatment, if they are having that acute heart attack, they're likely going to get aspirin, they're likely to get nitroglycerin, likely going to get heparin, possibly also going to get something like clopidogrel, which is Plavix, possibly also going to get a statin to treat the coronary artery disease that they obviously have. And finally, if they need oxygen and if they need morphine, they'll get those as well. That comes to the end of our lecture. Here are references for this lecture. Please subscribe and like our channel. If you have any questions, reach out and have a great day.